This has been commissioned by MSD and could not be a more important topic at this time. And I'm really pleased that everybody's here to listen to this, and particularly that the ILC is providing a new report today for us all to think about, and we're going to have a great discussion about it, and hopefully lots of questions and answers during that time. I think you know that over the course of the year, ILC has been speaking to lots of different experts in immunization, from government, local authorities, and lots of healthcare professionals, to discuss how the delivery of routine immunization in the UK could be optimized now that we have the public thinking very much more about vaccinations and the importance of defeating infectious diseases. How will COVID-19 really affect those routine immunizations and the delivery of them? So I'm delighted that Liam Hansen, the Communications and Engagement Officer at ILC, is going to be presenting the policy briefing, which collated these views and makes really interesting recommendations on what the system can do to improve routine vaccination, and to really look at uptake numbers and how can we ensure that more of our older adults and adults in general take those vaccines that they're offered. Next, our expert panel, after Liam's presentation, will respond to the recommendations of the briefing, and they're going to share their thoughts too on how we can improve routine vaccination among all ages, actually, in the UK. So we're going to hear, a real expert opinion on that, and then we'll have questions and answers. And I know many of you listening will actually have expertise yourself, will want to comment on what's being said, and ask specific questions perhaps around the presentation of Liam and of the experts. So I think a really exciting early afternoon. It's my job as chair to give you the housekeeping issues, and given that it's usually where are the toilets and the fire escape, we're not going to be doing that today on the internet. But I do understand the internet issues. We can get technical problems, so bear with us if that happens. We don't think it will, but just bear with us if it does. At the bottom of the screen, you're going to see the chat function, which allows you to communicate with the panelists, the delegates, as well as the Q&A feature. So I hope you'll be very active in that. Be great if you could keep your answers or your comments short and focused, so that we're able to really move quickly through topics. And if you're having issues yourselves with the audio video, you can connect through the Ethernet cable, I'm told. I'm not sure what that is myself, but I've no doubt that many of you will know what that is, or through the hotspot on your phone. It would be great if you could post comments on Twitter using the hashtag #ReadyToRollOut and @ILC UK. And just to let you know that the webinar will be recorded and published for public access on the website, the ILC UK website, and their YouTube channel. So there will be a chance to hear it again and to see the slides and have the recording, I understand, by tomorrow. So please submit your questions to our speakers using that Q&A feature, and we'll do our best to handle those as soon as possible. Again, thanks for joining, and I'm now happy to hand over to the report's author, the policy briefing's author, Liam Hansen, who is the who, as I described before, is the engagement Senior Director at Communications and Engagements Officer at ILC. So over to you, Liam.
Thanks, Shirley, for the introduction, and thanks everyone for joining us today. So I'm just going to start by introducing ILC in case this is the first time some of our audience have come to one of our events. So we're the UK specialist think tank on the impact of longevity on society. In other words, we're focused on making society work for everyone, regardless of their age. We're also one of the founding members of the ILC Global Alliance, which is an international network across 16 countries, all focused on the same thing, that is longevity. So in the presentation today, I'm going to start by talking about some of the context that led to this project, which Shirley did cover a little bit of at the start. And then I'm going to also speak specifically what was our reasoning on why we wrote this briefing that we're going to be talking about today. And then next, I'm going to talk through some of the content of the briefing, namely some of the barriers to routine vaccination uptake and our recommendations for improving it. So at ILC, we do a lot of work promoting immunization because we see it as a tried, tested and effective way to not only prevent disease, but also to improve longevity, and something that can work for people of all ages. So it's estimated that it saves around 6 million lives and tens of billions of dollars worldwide every year. So in March last year, we launched a report that was also commissioned by MSD on potential solutions to improve immunization coverage rates, specifically among older adults in the UK. But since then, immunization has become higher on the political agenda, potentially than it's ever been before because of COVID. So the pandemic has caused over 150,000 deaths in the UK and cost the economy an estimate of over 300 billion, but in fact, it's probably even more than this. So as a result, over the past year, we've been speaking to experts in the field of immunization to learn the lessons of this pandemic for routine vaccinations like pneumococcal or flu. So these conversations, like Shirley mentioned, occurred in the form of a series of working groups, which included representatives of the organizations you can see on screen. So I'd just like to take a moment now to thank everyone that attended these working groups, many of whom are in the audience or actually speaking alongside me in this panel today. And I'd also just like to take a moment to thank MSD for commissioning this work. So based on these discussions, we produced a policy briefing that we're launching today. The goal of the briefing isn't to make the case for why we need immunization. I think we can all agree that that's been made in the most brutal way by COVID. Instead, we're focusing on the how. So that is, how can we learn from the past 18 months and improve routine immunization moving forward? I think now is a particularly important time to consider this because we're approaching flu season and we also face the potential risk of a winter spike in COVID cases. So to move on to a bit of the content of the report, I think before we can decide on the solutions, we have to first talk about what the problems are. So before I start, we should recognise that the UK is a world leader in immunisation. We have relatively low vaccine hesitancy and genuinely good uptake rates. And in fact, nearly 90% of over 16s in the UK have had the first dose of the COVID vaccine, and nearly 80% have had both. But what the pandemic has also shown us is that we can't afford to become complacent when it comes to the threat of infectious diseases. And in fact, as you'll see from the next slides, things are far from perfect in the UK. So the first main barrier that we identified is inequalities in uptake, something which has been entrenched in the UK for decades, but has been further exposed during the pandemic. So according to the ONS figures on screen, uptake of the COVID vaccine has ranged by 19% between regions in the UK, with the lowest rates found in London. Uptake has also been lower among adults who live in more deprived areas, have never worked or are long-term unemployed, have no qualifications, or who don't own their own home. Even more so, ethnic variations have been a hot topic of debate during the pandemic. So uptake has been nearly 30% lower among people identifying as Black Caribbean compared to those identifying as white British for the COVID vaccine. But this isn't actually unique to the COVID vaccine. Similar patterns have been found in the past with the uptake of flu and herpes zoster vaccines. Secondly, people who identify as Muslim were 4% less likely to be vaccinated against COVID than those identifying as Buddhist, and even more so, 14% less likely than those identifying as Christian. So what we can conclude from all these inequalities is that while overall uptake for the COVID vaccine has been high in the UK, it's been far from equal throughout the country. Second barrier is awareness, specifically awareness of routine vaccination and their benefits. So it's clear that not everyone sees themselves as at risk from vaccine preventable diseases. and not everyone thinks vaccines are for them. In fact, many people continue to associate vaccines as something for children. As a result, generally, uptake for routine vaccinations is lower among adults than it is among children. In fact, uptake of the flu vaccine among older people is consistently below the WHO target in the UK, whereas we regularly surpass the target for routine immunisation uptake among children. There was some debate in our working groups about what the legacy of COVID would be for this awareness. Some pointed to the fact that many routine vaccinations across the world have dropped in uptake during the pandemic, and suggested that routine immunisation is at risk of being forgotten once we no longer have the threat of national lockdowns looming over our heads. But on the other hand, other people point to the fact that for the first time in the 2019-20 flu season, the UK did surpass the WHO target for flu vaccine uptake among older people. So there is a case to be made that the pandemic has proven the importance of immunisation and may keep it high on the political agenda long term. So it is unclear currently which of these futures is going to become reality, but we can't really afford to leave anything to chance, especially when it comes to infectious diseases. We have to try and raise awareness of the importance of routine vaccinations. But before I move on to how we might do that, I'm going to first talk about the last barrier we've identified, which is data, or more precisely, interoperable or inaccessible personal health data. So for a world leader in immunisation, the stats on screen are fairly shocking. There are currently 21 different electronic medical record systems currently in use by NHS trusts in the UK. And nearly a quarter of these trusts still use paper records. What this has meant is that in a 12-month period, there were 11 million cases where one hospital was unable to access medical data recorded at a different hospital. So if we can't effectively communicate about vaccination, we can't deliver it effectively. So now that I've talked about some of the problems, I'm going to talk about some of the solutions that we've come up with. First recommendation is focused on raising awareness for routine vaccinations. So during the pandemic, we've seen an unprecedented focus from the government on immunisation communications. So what we're proposing is to use some of this communication infrastructure for other vaccine preventable diseases. For example, that could take the form of weekly reporting on flu infection rates during the flu season, or using the COVID dashboard as a model for online hubs containing information about other infectious diseases. And lastly, expanding the Foreign Office guidance to include information on infection rates of other infectious diseases in foreign countries. Secondly, we also believe in the value of making an every contact count approach to immunisation. Healthcare professionals are a trusted source of information for many people in the UK. Therefore, during routine appointments, healthcare professionals should also prompt individuals to get their jabs. And if possible, they should even offer to administer the jab at the same time in these appointments. And this is something that's going to be particularly important if the NHS commissions COVID top-up vaccines this winter. So moving on, as we've seen from the inequalities I spoke about earlier, a one-size-fits-all approach to immunisation is not going to work. Marginalised groups need to not only be targeted by immunisation messages, but they also need to be involved in the creation of these messages. The government should therefore run focus groups with members of these groups to figure out what messages are going to resonate with them, which is as has been done for the delivery of the COVID vaccine. Lastly, sometimes who the messenger is can be as important as what the message says. Official sources of information are trusted for many, but not all, especially marginalised groups. Quite often, information from peers, families, and friends are cited as more important factors in whether an individual wants to get a vaccine. That means that what we need to do then is to use community leaders like religious leaders or celebrities, give them a key role in delivering immunisation messages. Saw a really good example of this earlier this year when Lenny Henry wrote a letter encouraging Black people in Britain to get the vaccine. So our second recommendation is focused on data. At its best, data can be used to monitor the threat of infectious diseases and identify low uptake segments of the population. But to do this, we desperately need to improve interoperability. Currently, NHS numbers are an underused universal form of identification that could support this if used right. Also, we could improve data collection by allowing community pharmacists, care workers, or other healthcare professionals involved in immunisation delivery to not only have access to online vaccination records, but also the ability to input the details of any vaccination they deliver directly into someone's record. Of course, though, this would need to be subject to a thorough vetting process. Also, when we're talking about health data sharing, we can't avoid the topic of data privacy. Public trust can be fostered by individual ownership of data. So allowing everyone in the UK to have access to their vaccination records via the NHS app is a good start. And nearly 5 million people have now downloaded the app. But if we think about it, that is still a fraction of the population of the UK. And does everyone that has the app know that they can access their vaccination records on it? The government also needs to bear in mind that not everyone is going to be able or want to use a mobile app. So to cater to different levels of digital literacy, there must also be an easy to access web-based portal for digital vaccination records. Moving on to our last recommendation, we know that immunisation can't be delivered at the national or the local level alone. There needs to be collaboration between the two. Currently, the healthcare system is in a period of transition with the introduction of integrated care systems and the new UK Health Security Agency. During and after this transition, we need clarity over the responsibility of different actors in the healthcare system. Strategic decisions, including on the development, approval, monitoring and supply of vaccines, should remain at the national level so that we can ensure central coordination. But immunisation delivery, on the other hand, is often best when it's locally driven by clinical commissioning groups, directors for public health and local governments, because they can draw on local knowledge of the infrastructure and demography of their communities. Therefore, they need to be given autonomy over how and where vaccinations are delivered. Second, vaccination has got to be brought to the people rather than vice versa. Administering vaccines in local settings like supermarkets, pharmacies, leisure centres has been very successful during COVID because it makes use of existing transport infrastructure and enables people to fit their jabs into their everyday routines. For the same reasons, allowing people to book and manage their appointments online has also been successful during COVID. Finally, home visits to administer vaccines for those who don't have the mobility to go to the GP or the supermarket or the pharmacy has been a successful strategy and another one that we should see continue for other vaccines. We also know that immunisation can't be delivered by primary care alone. During the pandemic, we've seen how effectively the expanded healthcare workforce, like community pharmacists, school nurses, care workers and midwives, can work together to administer vaccines. Several studies have found that their involvement in delivery of vaccination can actually improve uptake. And this may be thanks to the fact that people are often more familiar with these workers or the location of their workplaces. Also, so as a result, these actors should be given greater responsibility in the delivery of immunisation where possible. Alongside this responsibility, there should also be fair reimbursement that not only rewards these workers for each vaccination they deliver, but also gives additional rewards for hitting uptake targets. So I hope that's been a useful overview of the content of this briefing. And if you'd like to know about any of it in more detail, you can download it in full on our website. So now in the next stage of this project, we're going to be reaching out to the highest levels of government and healthcare systems to engage them with these recommendations. We're really welcome to any thoughts and ideas. So if you'd like to discuss any of what I've talked about further, or if you'd like to get involved in the project, please don't be afraid to drop me an email using the address on screen. Thanks very much.
Thank you very much, Liam. I know you galloped through that, but it's an excellent report and some really, really practical recommendations for how we improve uptakes. Great. I should apologise to everyone because I forgot to introduce myself. I would just say that I'm the former Chief Exec at the Royal Society for Public Health, and we did many reports on vaccinations and uptake and a variety of issues around them, partly because we believe that one of the greatest benefits in public health is immunisation. So I will say that we've got 4 reactions to Liam's report and the ILC report. And our first is the MP for East Kilbride, Dr. Lisa Cameron. And Lisa is the chair of the All-Party Parliamentary Group on Health, which is a really important APPG. And we're really interested to have your reaction, Lisa.
Thank you so much, Shirley, and thank you to Liam for what is a truly excellent report, so informative And thank you to the International Longevity Centre UK for all of the work that they've been doing in this realm, because I think it's going to be absolutely vital for the future health of our populations that we act on the recommendations that we've been hearing. Much of it resonates from what I've been hearing in my capacity as chair of the Health All-Party Group in Parliament, but also resonates in relation to hearing from local constituents in my capacity as an MP. I think it would be fantastic to have this presentation in Parliament as well, with the cross-party, all-party group and the peers and MPs who would be extremely interested to hear the recommendations, so that we can begin to start to make the case to government to take some of those forward. I think Liam, you really hit the nail on the head in a sense, in that it's not one approach fits all. What we've been hearing is that, particularly for those in rural communities, perhaps people with disabilities, those from more deprived areas, there has to be more of an assertive outreach type model and a locality model than essentially a central point where people can come to. Whereas when people are perhaps working or have more busy lives in towns, etc., they feel that it's much more central and easy to access vaccinations if there is a centralized point of delivery. So we were hearing very different messages from different communities, and depending on the makeup of people's daily lives as well. So for older adults and for those with disabilities, very much a clear message that has come through to the health group is a feeling of increased confidence when it's a healthcare professional who's familiar, perhaps at a GP level or a local community nurse, and particularly for those with disabilities who may have learning disabilities and be anxious about the vaccine, having some specialist input from nursing staff who work within disability settings can be very helpful for both families and for those residents and clients who wish to take up the vaccine but perhaps need a bit more support in doing so, particularly as those with disabilities have been adversely affected to a much greater degree with the COVID pandemic than some other populations. I think it's going to be especially vital to reach out to the most vulnerable cohorts across the United Kingdom and make sure that the message comes across. We've also been looking in the health group at the possibility of having an ongoing vaccines minister, what that might mean for policy making, rather than it being a temporary post, it being something that's firmly rooted in public health messaging and into government policy making too, to underline the importance. And I think the other aspect of that as well is the link to the UK's Health Security Agency, looking at pandemic preparedness, because we do know that this is just like the other threats that we may face internationally, that health security is now a particular aspect of research and of scientific expertise that we really need to harness and to resource. So I would just like to thank you once again for this report. I'm very keen that the recommendations are rolled out and gain awareness within the parliamentary groups. And the All-Party Parliamentary Group for Health certainly prioritises the work that you've been doing, sees great value in it, and thinks that it's going to be absolutely crucial for the future. So we want to support that work on an ongoing basis. Liam also touched briefly on data management, and that's another issue that the All-Party Health Group is prioritising moving forward. And we've had some good international discussions, particularly with ministers from Estonia, who speak about the utility in people having their health data at their fingertips and this being very transferable but movable with the individual and at the individual's level alongside the health level in terms of their record keeping. So some of those innovative solutions to data, I think, and technology are also going to be key. So those are my initial thoughts. Very supportive and thankful for your work. And I think, as I said, it will be very crucial moving forward that we harness the recommendations made. Thank you.
Thank you very much, Lisa. Really, a really great reaction, and so useful to hear that not one size fits all. And I think sometimes we're always anxious to find the one golden thing that's going to happen. And I think you reminded us that, you know, people in very different situations require different things, and a multi-stranded approach is clearly something we really need to embrace wholeheartedly. So thank you so much. And I know that you might have to leave us early, so thank you for making time with your contribution. We really appreciate it. So we're going to move on to our next speaker, next reaction. Joanne Yarwood, who is the National Immunisation Programme Manager for Public Health England, someone who I know many of you will know well, and she's been leading us. She's worked in immunisation since 1995 and has been leading on so many of the vaccine issues since PHE started in 2013. So looking forward to hearing from you, Joanne.
Thank you very much, Shirley, and thank you indeed for inviting me to comment today, and really to echo much of what Lisa has said. I do recognise, and many of the elements of the report resonate with me in terms of the national programme. And I think it's really important, and thank you, Liam, to acknowledge the existing successes of the national programme prior to pandemic, and also to acknowledge that balance of concern, shall we say, about what impact the pandemic will have on people's thinking about and understanding of infectious diseases. I'm an eternal optimist. And so I think what we've definitely seen is that people have been alerted to the significance and the importance of infectious diseases, and the impact, indeed, which we've seen throughout the last 18 months, the terrible impact in some cases that infectious diseases can have. And I think Liam mentioned complacency as part of the report. I think I'd like to highlight complacency as a separate issue, that actually we've been very, very fortunate, certainly in the UK, with our national vaccination programme, in that we so rarely see, prior to this pandemic, the impact of serious infectious diseases. And that's a great tribute, I think, to the colleagues who've been working in the programme for so many years, including all those colleagues who work in general practice, in school-age immunisation services, and indeed in other settings, for example, midwives, where they're delivering part of the programme. So we have been very fortunate in that our programme has been so successful. And certainly from the UK HSA perspective, that's something that we will want to build on and surely improve where we can. Interesting, Liam, I think that you raised the issue of focus groups. This is something we've been doing for many years in terms of how we best understand the needs of our target groups, if you like. And we also have had a great deal of learning from our annual surveys that we carry out of parental views, and more recently of adolescent views of the national programme. And we use that to feed back in, as you so rightly point out, into a better understanding of how we can better communicate with our target audiences, and to recognise that nevertheless there remain inequalities that we have to address and improve upon where we can through all of those various examples I think that you gave. And so I think it's equally important to think about trust in all of this. And I think perhaps that's already been raised, but we know from the surveys that we run that the highest level of public trust when it comes to immunisation specifically is in healthcare workers, in your recognised healthcare worker, your familiar healthcare worker, which I think Lisa rightly referred to, and also in the NHS, very high levels of trust in the NHS. So we're looking at trust in doctors, nurses, pharmacists, midwives, all very important. And that's where the public go as their first point of contact in routine times to ask about immunisation. And of course, all of that has to then be supported by communications at national, at local, and indeed at personal level with the public who are coming to us for advice on immunisation. I think we need to be a little cautious about making any assumptions of the long-term impact on health literacy of the pandemic. As I say, I've already said I hope that it will have a positive impact, but I equally think we have to build on those instances that we've seen where we can use, if you like, local colleagues to give the messages much more effectively than we can at national level. So I think you mentioned data, and of course there are not quite so many strands to data collection in the National Immunisation Programme, which is a good thing. And we are again very fortunate here to have probably globally one of the best disease surveillance systems. And it's very important because then with that data, as you so rightly point out, Liam, we are then able to understand the impact of any of the work that we're doing. So again, that's an area which we already have tremendous experience in, and we will be building on that as we go forward. I think as well, another issue that was mentioned is this issue of every contact counts. Absolutely. We all need to understand just how important immunisation is in protecting our health and well-being. And so as healthcare professionals or as teams working in any healthcare setting, it's going to be tremendously important that we're all, if you like, immunised literate and share the value of vaccine with each of those individuals that we see. And I think finally, the access is a key issue. I absolutely agree that it's really important that we address access, but I think again, and has already been acknowledged, it's not one simple answer. And PHE has done work right up until now, in fact, looking at why it is that certain groups of people don't want to vaccinate. And what we do see, and what has already been acknowledged, is that it's not just one simple answer. So it's really important that all the work we do is tailored to match the needs of the different sectors of our population so that we can see everybody getting the right access to the right vaccine at the right time. And so I think we can build on all of the successes that we've seen, both from the routine programme and also from the COVID rollout. And remember that in doing so, we're contributing on a personal level to every member of the population. We're contributing at a local level, at a national level, and indeed, we're part of a global movement to ensure that all of our people have access, as I said earlier, to the right vaccine at the right time in the safest manner possible. So thank you.
And thank you to you, Joanne. That was as brilliant as always with you. And I know that I like to say a big thank you to PHE for all the work they've done in this area, and they have really done a magnificent job. That it's not just a coincidence that we are one of the best countries in the world for vaccination. It's because there's been a lot of professionals behind that, making sure that that's remained the case. So we're really very grateful. Thanks.
Well, thank you on behalf of all my colleagues. Thank you.
I'd now like to introduce our next presenter, reaction to the report, and that's Dr. George Cassianos, who is the National Immunization Lead of the Royal Society of General Practitioners. So we all know that GPs have played a huge role in this. And I should say too that he is also the president of the British Global and Travel Health Association and published widely on vaccines. So I think we may get an international perspective as well. So thank you for presenting, George. Looking forward to hearing what you have to say.
Thank you, Shirley, and thank you to Liam for inviting me to respond to the excellent report. And the way I'm going to respond is to actually show how general practice is responding to this report. And we have already started doing so, because we have had a new contract for vaccinations and immunizations introduced on the 1st of April this year, which I believe is going to really prevent infectious disease across all ages. Next slide, please. In order to understand how it was before and why they need to change, here are the targets we had for the under 2-year-olds and under 5-year-olds for general practitioners to reach. If a general practice reached 70% vaccination rate of the children, say, they got 1/3 of the payment. Once they reached 90%, they got 3/3 of the payment. That meant, next slide, that any inner city practice which achieved, say, 69% vaccination rate was running at a financial loss. They were getting absolutely nothing. While a practice that reached 90% could relax now, but we needed to achieve much higher than 90%, 95 and above. If you look at the adult vaccination, it was actually, again, we were seeing lower vaccination rates than what we expected. But there was one great success, and that's QOF, which that's why we call it in general practice, is quality and outcomes framework for influenza vaccination of 4 specific conditions: coronary heart disease, COPD, chronic obstructive pulmonary disease, stroke, TIA, and diabetes. And I'll show you in a minute what I mean by that. Next. The other problem we had, there was this global sum, which is how GPs are paid in a global sum. But there was this childhood non-target and other vaccinations, and we didn't know which vaccines are there. You could actually say it is there. You could say it's not there. There were arguments. Now we are very clear when it is our responsibility to go ahead and vaccinate. Next. Now you can see here in the dotted line, it was 2019, and in continuous line, 2020, where the first vaccination, the hexavalent was. We will really reach well above 95% for the first dose of the hexavalent, but second and third dose were actually lower, in fact, under 90%. Next slide. If you look at the measles vaccination, again, with the MMR, it was below 90% for the dotted line 2019 and continues 2020. But we needed to achieve 95% vaccination rate with MMR if we were to interrupt transmission of the measles virus in our communities. Next slide. If you look at the pneumococcal vaccine, the chest infection vaccine, as patients like to call, at 65, patients were eligible, unless they had a chronic disease, to have the vaccine. And you can see the bottom line, 65, how low it is. You had to wait for 10 years to get to the red line, the top, at the age of 75 to ensure that you had your vaccination. No good. We needed to do it earlier. Next slide. And here you can see in dark green the 2019 and in lighter green 2020, the first 2 quarters of the year for vaccination against shingles. Yes, we dropped in April and June. We had the lockdowns. We picked up by September, but the vaccination rate is even below 30%. No good. We need more than double that. Next slide. This is very important for the International Longevity Center because what it shows is the functional decline in older adults, number 1 line, because of we get older. And there is a decline in physical and or cognitive performance. But anytime we get an acute disease, number 3, or a chronic disease, number 2, we actually decline further this functional decline we're getting. So we really need to prevent disease where we can. And we have got a lot of vaccine preventable diseases. An example here can be an acute disease, shingles, and a chronic disease, post-herpetic neuralgia. Next slide, please. So what we did in 2019, in the summer and autumn, we were meeting at the Department of Health to really think how we can improve vaccination of our population. And it was the Department of Health, it was the BMA, the Pharmaceutical Services Negotiating Team, Public Health, Mary Ramsey, I represented the Royal College of GPs, the Royal College of Nursing. We were all there and we were thinking how to do it. And we put some ideas in this report, which we published. Next slide. And what you see here is what we were trying to do. We were trying to incentivize achievement of really good uptake rates in vaccination. But at the same time, there was a lot of administration in general practice. We needed to reduce that burden for practice managers. We needed to clarify what do we mean by call and recall. We needed to incentivize particular vaccines because the vaccination rate was lower. We needed to sort out whose responsibility is when there is an outbreak or a catch-up program. We needed to reduce complexity, and we needed also to support the primary care networks. Next slide. And the new contract came in on the 1st of April, and practices that we were going ahead with that needed to sign up by the 21st of August this year. Once we sign up, we are committed to these 5 core contractual standards. 1 is to have a named lead for vaccination services who is going to drive vaccination in every practice, in every primary care network, and liaise with outside agencies. If a child is not vaccinated, somebody needs to know outside the GP practice, and therefore they will liaise with other agencies and so on. Provision of sufficient convenient appointments. Our chair has actually mentioned her role in the Royal Society for Public Health, and of course, moving the needle, a superb report. If you haven't seen it, please look at that report. And what the patients were telling us, healthcare professionals, is that we're not giving them convenient times to attend, and availability of appointments was a problem. It needs to be sorted out. It is in the core contractual as a contractual standard. Then it was the call and recall programs and opportunistic vaccination. We needed to augment this. And Joe has actually mentioned that. And of course, we needed to sort out what is the role of general practice in participating in catch-up programs. And very important, the new contract sets standards for record keeping and reporting. Because if I do a vaccination and I don't record it properly, the IT system doesn't recognize it, and that child or adult actually appears as non-vaccinated. Next slide. And what we have done is this, that the NHS will pay a fee to general practice for every single vaccination they do within the general medical services, the GMS. And this is what we call the end session services. The childhood immunization, the children that come from 8 weeks onwards to get vaccinated, there is an item of service fee. Children who may have come from abroad, for example, and have an interrupted or incomplete or unknown immunization status, the school children who receive the tetanus, diphtheria, polio, their HPV, their meningitis vaccine, also the meningitis for students at universities, adults, shingles, pneumococcal vaccine, but also other vaccinations. For example, maybe a baby born to a mother who is hepatitis B virus positive. Pertussis also vaccination for pregnant women. Next slide, please. And this is the very successful QoF, where you see the 4 domains, 4 diseases. And to get you to understand how it works, each point is about 195 pounds. So if I achieve 55% vaccination rate of my coronary heart disease patients, I get no points. But at 56%, I get 1 point. But if I hit 96%, I get 14 points. So you realize in my practice, these patients are near 100% vaccinated. This was the success of QoF. Next slide. But it needed to go. Why? Because we have got other vaccines that we want to encourage vaccination at this level of vaccination. Next slide, please. And here they are. And the new contract with QoF actually indicates that there are points to be made for the diphtheria, tetanus, and whooping cough for babies. And this is what the hexavalent is. And there are 3 points if we achieve 90%, but there are 18 points if we achieve 95%. Similarly, for the first MMR, which we give between 12 and 18 months, and for the preschool vaccine, which is the diphtheria, tetanus, cellular pertussis, polio, but also by then, before the child is age 5, we ensure that the child has had 2 doses of the MMR. There was also a need to improve the vaccination rate of our older adults, 70 to less than 80 years of age, as regards to shingles vaccination. And you can see there, if a GP achieves 50%, you saw it was 30% before, 50%, we get 0 points, but above that we get points. At 60%, we get 10 points. So that will encourage general practice to do the same as we have done for influenza QoF. Next slide, please. Now, what happened to influenza has not been lost, because influenza vaccination of the children, 2 and 3 year olds, and those in the groups at risk, and also adults with the seasonal influenza, attracts a fee. So does also COVID-19 vaccination under what we call enhanced services. Next slide, please. So the NHS is actually putting money in the Investment and Impact Fund, IIF, for these 3 domains. You can see here that the 65 and over, we are still encouraged to achieve 80 and 86% if possible. That's when we're going to share those £9 million actually put in. The 18 to 64 command the largest fund, 19.8 million, and we need to achieve 90% vaccination rate if we are going to achieve that. Last year, we achieved about 54% vaccination rate. And the 2 and 3 year olds also command about 3.2 million to be shared among those GPs that will achieve this. But this has to be achieved in a primary care network environment. So if my practice achieves, for example, 88% vaccination rate of the 65s, that's what we did last year. And the 2 practices that are connected with us in primary care network, we don't get this reward. I have to make sure that the other practices also achieve this. So we're working together, and that is what it's all about, to actually encourage and improve and help primary care networks. Next slide, please. So in conclusion, ladies and gentlemen, the new GP contract reduces that administrative burden the practice managers had. It incentivizes achievement of very high vaccination rates. It says core standards that are very important if we're going to have proper vaccinations, immunization services in general practice. And it also encourages vaccinators to prevent infectious disease across all ages. I would like to thank you very much for your attention.
Thank you very much indeed, George. That's so fascinating. And I'm sure that many of us hadn't understood properly some of the barriers that you had mentioned that GP services that had existed previously, and how the new contract's really going to help overcome some of the barriers that to uptake that we're here to discuss today. So that is absolutely really fascinating information, and so welcome to see the new contract, and that the administrative burden particularly has been taken off. So thank you so much for your presentation. We're now moving on to our last one in the reactions, and that's Rihanna Ahmed, who's the Immunization and Commissioning Manager for NHS England, and she's the lead in the London region. So welcome, Rihanna.
Hello, can you all hear me? Just give me a thumbs up because I'm using my phone and I'm very, very sorry. Thank you, that's great. We're really delighted to be joining you here today, and thank you for giving London Region an opportunity to share what we're doing. As Commissioners of Immunisations, we have found that the pandemic has very much raised the profile of our work, and everyone suddenly is interested in immunisations and, you know, the benefits to society of, you know, this whole raft of immunisations. And we've all seen, with COVID, the scramble to get an effective vaccination, and how the world stood still. So it's such an important area of work. I mean, although we are still in a pandemic, it's a bit premature to be talking about post-pandemic, and you know, it can't come too soon as being in post-pandemic. However, just to kind of say a little bit about London, we, as you know, we have many challenges of in terms of our communities, in terms of our commissioning and delivering of immunisations. We've got challenges associated with transient populations, the size, diversity of our population. So whatever the challenge is, you know, we are having to deal with it. So when I looked at the report recommendations, I thought they were very practical and doable, which is really, really helpful, because we all like things that are easy and doable and practical to do. So what I did was, if you go on to the next slide, please, I just kind of overlaid what the report recommendations were with what we were doing, and I'll kind of give you some case studies of what we're doing in relation to bringing these report recommendations to life, if you like. So in the next 5 or so minutes, I thought I'd give you, as I say, some examples of what we're doing under each of the recommendations. So there's a great little project in one of our local maternity units in North East London around the maternity immunizations, and then the recommendation on using personal data effectively for immunizations. We're doing some work with our child health information system, and general practice are doing a lot of work around using personal information to target text and email messaging to patients, and you know, that has had some degree of success as well. And then in terms of enabling effective collaborations on IMS at local and national levels, we're doing some great work with our local 5 ICSs in some very strategic work as well as practical work too. And then of course supporting our school age vaccination services on helping them catch up from a very turbulent year that they've had. So next slide, please. Right, that's great. So on to the this project that the Homerton did. So it's a little case study. So the Homerton is a hospital in Hackney, North East London, serves a very diverse population. The maternity unit there births around 5,000 babies a year. They also birth babies from neighbouring boroughs, including Waltham Forest. They birth a lot of their babies there. So in relation to the childhood IMS and flu IMS in Hackney, Hackney is often has the lowest uptake in London, and there is a very low uptake of flu and pertussis as well. So as we know, the pandemic has highlighted these very stark inequalities, and in light of this, the Homerton were quite concerned that certain groups are already not taking up vaccination offers. So this is in the pre-pandemic world, and definitely in the post-pandemic world, there was a lot of fear that we saw people weren't coming out for their vaccinations. Pregnant women were afraid to go into hospital because they might pick up COVID from there. So the Homerton Maternity Unit did a quality improvement project that comprised 2 strands. And firstly, we've got a really fantastic consultant midwife who worked with patients from a Black and mixed heritage background. So they were service user leads, and she just wanted to understand what would encourage people to come forward, for pregnant women to come forward for their immunisation. So what she found from them was that they wanted information presented and reframing in terms of the benefit of immunisation, rather than, you know, if you don't get immunised, you're going to get this, this and this. So it was about talking about the benefits rather than the risks. Now, had she not done this co-production piece of work, this very great nugget of information would have been lost. So with their input, there was some materials which I'm going to show you in a minute. The unit produced some information on, it was for flu and for pertussis, maternal pertussis as well. So what they found was that the women actually wanted more detail about what's included in the vaccination, and, you know, more information to give them an informed choice as well. So this information that was produced by the Homerton's Maternity Voices Partnership was also shared with the advocates from the Orthodox Jewish community, and it was shared in paper format. So communities who don't use social media were also able to access this. And then the second strand of this quality improvement project was to open up a second site in the maternity unit. So it's expanding the capacity and provision, which meant that the women were offered vaccinations at multiple times. They had several opportunities for conversations about the importance and the benefits of being immunised. This consultant midwife does a lot of public health updates as mandatory training with the midwives. So, you know, they're all up to date with their training. And I'm delighted to report that from being one of the bottom in the sense of immunisation uptake rates, they were quite low, but now they have increased their uptake rates, and they are in fact the best in the North East London suite of hospitals. They had women queuing round the block for their flu vaccination. They had to reorder. They'd ordered so this is last year. They reordered more stock because, you know, they literally could not keep up with demand. So it just shows that when you're co-producing information that's aimed at the population that you want to target, it does reap benefits. Now, this is the information leaflets that they produce. So these are posters. So there was a series of them, and this is about what the flu jab can do for you in terms of benefits, what it has, and why it's necessary for you to have a flu vaccination in pregnancy, There was a link to coronavirus and why it's important for you to have a flu vaccination and where you can get your flu vaccination from. So you've got your friendly midwives here in this picture on the bottom right of the screen. So next slide, please. Okay, so that's the co-produced comms there that we're talking about. So in terms of the effective use of personal information, we're doing a number of things at regional level with our child health information service. So we are doing weekly notifications to practices to remind them of babies and children who are due their vaccinations, and so the practices, work through that. And this we've got another exciting project where we are using personal information, i.e. telephone numbers, to remind parents that their child is due for an immunisation. Now, this is a work in progress in that it hopefully by the end of this month, beginning of October, this will go live. In terms of what the PCNs are doing and what general practice are doing, we've also got that they're also doing centralized call and recall. So this is really, really important. And what they've organised themselves locally in terms of dedicating their efforts to particular age cohorts. So you've got nurses, for example, in this particular practice, we've got 3 nurses, each take responsibility for one age group, and they contact the overdues and those parents who are dithering, that they're a bit unsure. So when conversations take place, this tends to generate more success in booking them in. So it's really, really useful for practices and CHIS to use personal information to proactively target, and as we can see from this study, it does generate in success. And then of course the text messaging as well. And it's really interesting when I was speaking to a couple of the nurses about how they're finding text messaging. They're actually saying that there's a lot of different communities are IT, have different literacy levels in IT, but these nurses working in very deprived inner city areas with very diverse communities have told us that parents are coming out, they expect text messages and they respond to them, and it's quite immediate. So yeah, this sort of thing does work. But overall, having confident and experienced nurses is absolutely crucial in that they can encourage, persuade, educate, and provide the reassurance to parents who are doubtful or a little bit hesitant there. Next slide, please. So the final slide really is about this business of collaboration, and it absolutely is key and crucial. So we have 5 ICSs in London, and we have each of the ICSs have appointed immunisation directors who jointly chair immunisation boards in their areas. They set their own priorities for improvement, they set their own agenda, and this is coming from a position where we were doing all the IMS boards as a region, as NHS England. We were doing everything, but the interest, the enthusiasm, the appetite to collaborate has really, really ramped up. We have provided some practical support as well. So in terms of financial support for each of the ICSs to employ around 7 immunisation coordinators who would do that direct supporting of the practices. So we have just handed over quite a substantial amount of money to the ICSs so that they would take, they're responsible for everything, the employment, the trade, everything. So they're taking the lead on that. And then on a more practical level, our ICSs and CCG leads support us on programs like neonatal hepatitis B, where there is an identified risk of a delay, or support with an incident where an immunisation, where a Hep B immunisation hasn't been given, where it's been late. They really do kind of roll their sleeves up and really get their hands in. So, from strategic level through to the very practical support on a programme, they are there and, kind of shoulder to shoulder with us as well. And there's a lot of collaboration at local level, at PCN level, where local authority, public health teams, where school-age immunisation providers, everybody collaborates to make sure that messaging is getting out there to the population around the importance of immunisations, and how and when to avail themselves of an immunisation offer. And finally, one of the things that we did in our region, I just mentioned the fact that the school-age providers have had a very turbulent 18 months where they've had to put up with school closures, and they've, it's just been incredibly hard for them to get into schools. So we requested our practices, our general practices, to opportunistically offer teenagers who were presenting for a routine appointment just to check their immunisation status and, vaccinate them where they hadn't been vaccinated. And the very final slide is a huge, massive thank you to Tamsin, who's the consultant midwife at the Homerton, and a couple of nurses, Linda and Lucinda in Tower Hamlets. They're the real heroes. They are at the forefront of this. We commission. They're the ones that actually do the vaccinating, the jabs in arms, and without them, we'd all be a bit stuck. So huge thanks to them, and thank you.
Thank you very much indeed, Rihanna. That was, really quite inspiring to see how in London these programs, how you're doing this in practice, what it takes to do this in practice, and how you've got such great leads on this. So very interesting, and hope you'll be sharing the data with others so that it can be replicated perhaps in other regions of the UK. It's really great to see programs in action, if you like. So many thanks from all of us. So now we're on to the question and answer section, and many of you have been putting in your questions during this time, and there were a few from beforehand. So I think we'll kick off. I'm going to conflate a couple. First to you, Joanne. So we have a question from Moses Azzopardi, and apologies if I haven't said that right, Moses. And that's a very practical question, which is the Johnson vaccine accepted in the UK? And then I'm adding on to that is from Rekha Shah, who asks, when will community pharmacy be able to deliver other vaccine programs other than flu and what they're doing already? So I think a couple specifically there for you, Joanne.
Okay, thanks, Shirley. So I'm presuming you mean the Hansen vaccine, and yes. I could put into the chat, it is approved by the MHRA. So I'll just put, I think, yeah, that's the link that you can use there to see the details of that. So I think that answers that particular question. And the question about pharmacy, that's outside of my remit, I'm afraid, and I think is for negotiation elsewhere. So right. I'm sorry, but I can't answer that question.
So I'm really interested here on the Johnson & Johnson, the vaccine. Myself, as my daughter had that when she was in the USA. So we're all hoping it's accepted everywhere in our family, at least. So on to some other questions. Gary Finnegan asks, how can the high uptake of COVID-19 vaccines be translated into better flu vaccine uptake? Because we know that's been, you know, up and down. Who would like to answer that? Could you thumbs up to me if George, Rihanna, or Joanne would like to do that? George, would you like to take a stab at that one?
Okay. Yes, and what we have learned very well to do with the COVID vaccination is mass vaccination. And we are becoming experts in that. And in fact, abroad, they ask us, how do you do it? Now, if we can give the flu vaccine with the COVID vaccine, and we are waiting to hear about that very, very soon, imminent in fact, then I can see that we're going to continue with mass vaccination for COVID vaccination. And at the same time, if somebody is eligible for an NHS flu vaccine, we will do that as well. There are some logistical problems because GPs have purchased the flu vaccines and they're going to be in their own surgeries, but the vaccination may happen somewhere else. But that can be sorted out with the MHRA and so on and so forth. Don't worry about that. As long as we get the go ahead, then we will vaccinate for COVID as well as influenza. Otherwise, influenza vaccination will be done individually in the PCNs, primary care networks, or practices, as we did last year. And I'm sure we will be aiming for 90% vaccination rate across the board.
Thank you very much. That's very helpful, George. And it'll be interesting to see how many vaccines can you pack into one session. Perhaps that's what you'll be looking at over the longer term here.
Well, what we have done, Shelley, is this, that as people come and get vaccinated, we are searching who has not come. And it's a Saturday morning, and we're texting them. And when they come, we say, you need your pneumococcal vaccine as well. By the way, you haven't had your shingles vaccine. Now we're talking only now giving flu vaccine, because once we start giving COVID vaccine and the shingles vaccine, that's a different thing. At the moment, we have to separate them by 7 days, but we search on the computer continuously to see what other vaccines they have not had, and we offer it to them. If they accept it, we vaccinate.
That's fabulous to hear, that very specific targeting. So thank you for that, and for all the other GPs who are doing that as well, George. That's great. Your answer is slightly linked to this next question, which I'm really interested in myself. Richard Ashton asks, how can the immunization system service play more of a role in addressing the social determinants of health, which could impact health inequalities? And we're all so aware of health inequalities, but COVID, I think, has brought this into such relief. I might ask you, Rihanna, for your, as you've obviously been doing work in this area, to reflect on how the immunization service can best deal with the social determinants.
No, absolutely. Obviously, we can't deal with all the social determinants of health, like the poor housing and all the rest of it. But in terms of making things more accessible, more outreach, we on our flu programme for this year as commissioners, we have looked at the insights into how people from different health inclusion groups access the COVID vaccination, and we are applying these lessons to flu. So, for example, we have service level agreements that allow GPs to vaccinate anybody that's unregistered, so they can go out and do outreach to homeless populations, asylum seekers. You know, they've visited through the PCN networks. They've visited homeless hotels. There's a piece of work that we're doing around sex workers and their access to immunisation. So we've commissioned SLAs, and this type of thing needs to be more routinely commissioned. It shouldn't be a marginal add-on. It should be part of how we commission things routinely. So we have started to do a lot of that work. It's actually going out there. I think it was Liam that was saying, go out to the communities, don't expect them to come to you, and that's what we are starting to do. So it is commissioning in a more effective way, and we can do that. It's not beyond the wit and wisdom of commissioners to do that. And if there's a willing provider, then we should be able to do that. Yeah.
That's great, and I love it, all the willing providers and everybody working collaboratively. Liam, perhaps I could ask you from the various recommendations, which you think would be most effective on Richard's question around the social determinants?
Yeah, absolutely. I think it is a really good question, because when we've seen from other research that we've done that there are massive gaps in life expectancy in the UK. And there are massive socioeconomic inequalities. And that's kind of what I alluded to at the start, that these aren't new. The inequalities I highlighted aren't out of the blue, they're not new. And similarly, we have this difference in uptake of vaccines, which obviously leads to a worsening inequalities, because if you don't have your vaccine, you're more likely to have conditions as you grow older. And George had a really good chart that showed that about how our health does decline as we age, but it declines a lot more rapidly if we have acute diseases or chronic diseases. I think from the report of like how to address this, I think a lot of it is about that one size fits all approach not working, and like what Rihanna said about having co-produced messages. I think it's very hard to talk about what causes these inequalities because it isn't just one thing. But something that can be the case is trust. And I think if you involve people from these communities in the decision making and the campaigns, then that embeds trust, because they know that this is their community that has decided this. And I think as well, having figureheads, like I mentioned about religious leaders and celebrities, but also healthcare professionals that are from those communities themselves. There was an example that I put in the report where 2 Muslim doctors came out during Ramadan and said that it does not break Ramadan to get your COVID vaccine. And I think those sorts of things is what embeds trust and makes it know that they are being considered, they are being included. So I think it's about not doing a blanket approach and making everything a bit more targeted.
Thanks, Liam. That's really helpful. And I've got a comment here that I'd like to read out, because somebody backing up what Rihanna is saying, but also taking it a step further. So Rika Shah says here that the outreach work with flu has not been limited to just GP practices, but the London region, you've done all sorts of work, as you said, providing additional capacity in the system. So I think people are recognizing the work that you're doing in the commissioning, Rihanna, that you're finding the people to deliver, and also that you are providing the funding to do that. And those two things together can really make a difference in communities, clearly.
Yeah, I just to add about it. So our commissioning should be informed by evidence and data, and we have done some interrogation of our uptake data, and we found that if you were living in a more deprived area, your refusal rate, your decline rate was higher, and you were of particular, so if you're from the Black Caribbean or Black African community, again, you were less inclined to take up an offer of a flu jab. So using that insight and using that data, we again, as Liam has said, we are trying to use professionals from particular backgrounds to get messaging out there, to really focus on trying to turn the declines into consents and to get these people vaccinated, because they are disproportionately impacted on from flu, COVID, that kind of thing. So we do, it's really important as well to use data and insights to inform your commissioning.
Yeah. Thanks for that.
Just to in on that as well, I think it's really important to talk about these groups, that there is like the anti-vax label is really often just slapped onto people. Really, anyone who doesn't feel that they should get a vaccine are labelled as this, and it's associated with all sorts of things like populism and a mistrust in institutions. And I think it'd be easy to just go, well, these people are anti-vax, this religious group or this ethnicity, and they will never do it. So I think it's really promising to hear from George and Rihanna that obviously don't think that in the slightest. But I think it's something as well to just kind of recognise it at a system level of actually you can have someone who has their concerns about the vaccine and maybe even legitimate concerns about the vaccine and respect that opinion and talk it through and really listen, I guess, to what people have to say and not just label them with this populist anti-establishment label.
That's such a good point, Liam. I know that RSPH, we talked a lot about vaccine hesitancy because people had questions they needed to be answered and reassurance. They needed a reassurance about certain things. And I know that PHE thinks that too, that's such an important aspect to get all your questions answered and because everybody, may have different views on things. And so we need to be open to those conversations and that will improve uptake a lot. I don't know, I think Joanne is still here, and Jenny Lippiat has asked, flu vaccine uptake was higher than previous years last year. Were there any indications as to why this was?
I think Joanne has actually had to leave.
Joanne had to go for another call. I can't answer that, but George, do you have any idea about that? Okay.
Yes, there was this urge to get vaccinated because we wanted the COVID vaccine, and that transferred itself onto influenza vaccine because we didn't want also influenza and COVID. And in fact, if you have COVID, you have one chance of dying. If on the top of COVID, you also get influenza, your chance of dying increases by 2.7, more than doubles. And people knew that we didn't want two infections of the respiratory tract. And for one, we did have a vaccine, and people actually came forward. The other thing is that, and that touches on what we have just been discussing on this vaccine hesitancy. Sometimes it's not hesitancy, it's just that you didn't have a chance to get somewhere where you can actually get your vaccine done. And by opening up vaccination to the pharmacies, we have seen a tremendous improvement. Back in 2015, when the pharmacies actually joined the vaccination for adults 18 and over against influenza, they gave about 580,000 shots. Now, the last year, they gave over 3 million. Why? Because people find a better access in the evening on weekends to go and have it done. This is what we need to actually do. Bring the vaccines to people rather than hold on to them and wait for them to come to us. So I think that with COVID around, people will want to go and get vaccinated against influenza because they don't want to have both.
That's a brilliant answer. Thank you for that. Rihanna, would you like to make comment?
Yeah. Just to add. I mean, I think our pharmacists, our GPs, our general practice staff, and our maternity units, acute trusts, absolutely went hell for leather as well to vaccinate anybody that would come forward. We also had an additional cohort as well of 50 to 64s as well, which the pharmacists as well as general practice picked up. So that would explain kind of the higher uptake in terms of the higher number of vaccinations given. But also for the 2 and 3 year old children and the school aged children, mid-season, for those people who didn't want the nasal spray because of the porcine content, that also helped when they had the inactivated alternative. So where people refused on the grounds of, well, this vaccine contains porcine, for the 2 and 3 year olds, we saw a higher uptake, and we saw a higher uptake in the school-aged provision as well. But I think Dr. Cassianos is right. People were afraid, there was all this fear about COVID, and there were these messages around, the very severe impact of flu. We didn't have a jab for COVID at the time, but we did for flu. So come and get your vaccine. Still, we can't be complacent. We still have a lot of work to do because there are still lots of groups that don't come forward. But I think all of our providers, pharmacy, general practice, those acute trust maternity units. Yeah, they've been amazing, worked so hard.
Thanks so much, Rihanna, for adding to that. I just want to draw people's attention to a comment by Tom Nutt from Meningitis Now, who said he was talking about the importance of rendering lived experience relevant, i.e. what happens when diseases such as meningitis strike in the absence of a vaccine. And that's where charities such as his Meningitis Now have a role to play as part of that collaborative approach. And it does remind us that there are diseases for which vaccines still do not exist. So Tom, thank you for drawing our attention to that and the importance of it. We are drawing to a close. It is 5 minutes, just a few minutes to go. And I want to say a hearty thank you to all our presenters today. A really rich discussion, great questions, and an excellent report from the International Longevity Centre UK. And I think lots of really great practical suggestions, and it's clear that we need to be sharing some of the great examples that Rihanna has outlined. We need to think about the issue of trust. I think that Joanne Yarwood talked about. The fact is that healthcare professionals in this country are all kinds of healthcare professionals are really trusted, and we must use them for the vaccine programs and to make the more successful and get that uptake up. And it was absolutely fascinating to hear about the technical issues, George, around the contract, what was the previous contract, what the new contract does, how it opens up things. And I did not know, and I was really interested to hear about the PCN network and how in that collective you're able to push each other to do better on the uptake so that it becomes a bit competitive, and the incentives so that everybody in the network works together to get the uptake up. And of course, underlying this whole discussion has been around the inequalities, and that the uptake, people in that last group of people often who have not had the vaccine are living sometimes in worse circumstances. That there are many reasons why they're much more where we need to get to them. We need to make it much easier to access and the vaccine program. So I think all of the comments today have been really, really interesting. Thank you to all of the people who've joined our webinar today. And I should tell you that the ILC are running another project on immunization commissioned by MSD. This focuses on at-risk groups, which are really important. This is going to be on September the 22nd, where they're launching a report on what charities can do to improve routine vaccination uptake among at-risk groups. So again, looking at a different set of institutions that can support that. And do keep having a look on the ILC website, ilcuk.org.uk, because that will keep you up to date with all of their things. I would urge you to follow them on Twitter and YouTube for all the latest information from them on their webinars. This will be on YouTube, and this webinar will also be on their website, so it will be people will be able to access our discussion today by tomorrow. So thank you so much to ILC for running this webinar, to our speakers Liam Hansen, Dr. Lisa Cameron, Joanne Yarwood, Dr. George Cassianos, and Rihanna Ahmed for giving their reactions to the report. And a really big thank you to all of you who've joined us, because they're great questions, and I'm sorry if we didn't get a time to answer them all, but I'm sure that ILC will try and get every single question answered to you as soon as possible. So many thanks to you all for your participation, and hope to see you at the next one. Thank you.
Thank you.
Bye-bye.